Before we begin, a quick disclaimer. The information in this video is for educational and informational purposes only. It is not intended to be professional career, financial, or legal advice. You should consult with a qualified professional before making any decisions based on the content of this presentation. All career paths are unique, and your results may vary. There are over 33 million people working in the United States healthcare industry right now. That's 1 out of every 10 people in the entire country. But there's a new role emerging from the shadows that is set to become one of the most critical, most in demand, and most lucrative jobs within that entire system. And the crazy part? Most people have never even heard of it, or if they have no idea what it actually means. I'm talking about the Health Data Analyst. The Bureau of Labor Statistics projects that jobs for data scientists and analysts will grow by a staggering 35% over the next decade. That is 10 times the average for all other occupations. It's a tidal wave of opportunity, and a massive portion of that wave is crashing directly into the world of healthcare. So what if I told you that you could build an incredibly stable, high-impact, six-figure career at the heart of this revolution? A career where you solve life-or-death puzzles every single day. A career that, in many cases, doesn't require a PhD, a master's degree, or even a specific data science background to get started. Would you be interested? If you're watching this, you probably are. You've likely seen the job titles pop up on LinkedIn or Indeed: Healthcare Analyst, Clinical Data Analyst, Healthcare Informatics Specialist. The titles sound impressive, the salary ranges look tempting, but they're surrounded by a fog of confusion. What do these people actually do all day? Are they just staring at spreadsheets in a hospital basement? Are they coding from sunrise to sunset? Is it boring? Is it meaningful? How do you even get a job like that? This is the exact problem we are going to solve for you right now. Over the course of this presentation, we are going to pull back the curtain and demystify this entire profession. We are going to give you a crystal clear, no-fluff, day-in-the-life look at what a health data analyst in the United States really does. We will break down the exact skills you need, the tools you'll use, the different types of roles that exist, what you can expect to earn, and a realistic roadmap for how you can break into this exploding field. By the end of this, you will know with confidence if this is the right career for you, and you'll have the foundational knowledge to take the next step. So, let's start with the most important question. What is a health data analyst? Forget the boring textbook definitions. I want you to think of a health data analyst in two ways: as a medical detective and as a data-driven storyteller. First, the detective. Imagine a hospital is facing a crisis. There's a sudden unexplained spike in post-surgical infections in the orthopedic wing. Patients come in for a routine knee replacement. The surgery goes perfectly, but 2 weeks later they're back with a dangerous infection. It's a nightmare for the patients. It's costing the hospital millions in readmission penalties, and it's damaging their reputation. The chief medical officer is panicking. She has 1,000 questions and 0 answers. Is it one specific surgeon? Is it a contaminated batch of surgical tools? Is it the new cleaning crew they hired? Is it related to the patient's age, their pre-existing conditions, or the time of day the surgery was performed? They have suspicions, but they have no proof. They are lost in a sea of data. This is where you, the health data analyst, get the call. You're not a doctor, you're not a nurse, but you have a unique superpower. You can speak the language of data. You step into this chaotic situation, and your job is to find the truth buried in the numbers. You start by pulling data from dozens of different sources. You pull electronic health records, surgical logs, pharmacy records that show which antibiotics were prescribed, lab results, and even staffing schedules. At first, it's just a massive, messy jumble of information, millions of rows of data that look like nonsense to the untrained eye. But then you get to work. You use tools like SQL to query the databases, pulling only the specific information you need. You use Python or R to clean that data, fixing errors and standardizing formats. You start looking for patterns. You analyze infection rates by surgeon. Nope, it's happening across the board. You analyze by surgical tool supplier. Nothing there. You analyze by time of day, by operating room, by patient demographic. And then you find it. A faint signal in the noise. You notice a slight correlation between the infections and a specific post-operative drug that was recently introduced. So you dig deeper. You build a statistical model. You create a visualization. A simple, powerful chart that shows a clear spike in infections starting on the exact date that this new drug was rolled out across the hospital. You've found the culprit. You've solved the case. You're the detective who cracked it not with a magnifying glass, but with data. But your job isn't done. Now you have to become a storyteller, because finding the answer is only half the battle. The chief medical officer, the surgeons, the head nurses, they aren't data scientists. They don't want to see your complex code or your raw statistical outputs. They need a story. They need to understand the what, the so what, and the now what. So you build a dashboard. You create a presentation. You stand in front of the hospital leadership and you tell them the story. You don't start with the technical jargon. You start with the patient. You say, "We had a problem that was harming our patients and costing us millions. We investigated, and the data tells a clear story." You show them that simple, powerful chart. You explain in plain English what it means. You recommend an immediate action. Pause the use of the new drug and revert to the old one while the pharmacy investigates further. You've taken chaos and turned it into clarity. You've taken data and turned it into a decision that will save lives, save money, and protect the hospital. That is what a health data analyst does. They are the bridge between the chaotic world of raw data and the real-world decisions that impact patient care and the business of healthcare. This role has become so critical in the US for three main reasons, and it's a perfect storm of opportunity. First, the data explosion. For decades, medical records were just paper files sitting in a cabinet. They were impossible to analyze. But with the widespread adoption of electronic health records, or EHRs, every single patient visit, every prescription, every lab test, every diagnosis now creates a digital footprint. Hospitals and insurance companies are sitting on mountains of this data, and for the most part, they have no idea how to use it effectively. They are data-rich but information-poor. They need analysts to turn that raw data into gold. Second, the cost crisis. American healthcare is astronomically expensive. There is immense pressure from the government, from insurance companies, and from patients to reduce costs and eliminate waste. How do you find that waste? You can't just guess. You need data. You need analysts to pinpoint which procedures are overpriced, which treatments are ineffective, and where the operational bottlenecks are that drive up costs. Health data analysts are on the front lines of making healthcare more affordable and efficient. And third, the monumental shift to something called value-based care. For a long time, the US system ran on a fee-for-service model. That means a doctor or hospital got paid for every single thing they did, regardless of whether the patient actually got better. More tests, more procedures, more pills meant more money. Now the entire system is slowly, painfully shifting to value-based care, where doctors and hospitals are paid based on patient outcomes. Did the patient get healthier? Did their chronic condition improve? Did they avoid a costly hospital readmission? To make this model work, you have to be able to measure everything. You have to track outcomes, quality, and patient satisfaction with incredible precision. And who does that measuring? Who builds the systems to track that quality? The health data analyst. This shift is fundamentally impossible without them, making them an indispensable part of the future of American medicine. So they are detectives and storytellers, working at the center of a massive industry transformation. But health data analyst isn't just one single job. It's an umbrella term for a variety of specialized roles. Just like there are different kinds of doctors, there are different kinds of health data analysts, each focusing on a different piece of the puzzle. You have analysts who work for hospitals, analysts who work for insurance companies, analysts who work for public health organizations, and even analysts who work for cutting-edge tech startups. Each role requires a slightly different focus and skill set. And understanding these distinctions is the key to finding the perfect lane for you. So let's start with the most common and perhaps the most intuitive role: the health data analyst working inside a hospital or a large healthcare system. Think of places like Johns Hopkins, the Mayo Clinic, or your local community hospital. These are what we call provider-side organizations because they directly provide care to patients. Imagine you're the CEO of a busy urban hospital. You're getting complaints. Patients are waiting for hours in the emergency room. Doctors are feeling burnt out. And worse, patient outcomes for certain conditions seem to be slipping. You know there's a problem, but you don't know why. It feels like trying to fix a complex engine while it's still running, and all you have is a wrench and a hunch. This is where the health data analyst becomes the hospital's most valuable detective. Let's call our analyst Sarah. Sarah doesn't wear a white coat or a stethoscope. Her primary tool is her laptop. Her first step isn't to walk the ER floor, but to dive into the hospital's data warehouse. Her main source of truth is the electronic health record, or EHR. You might know these by brand names like Epic or Cerner. Think of the EHR as the digital brain of the hospital. It contains every single detail about a patient's journey. The time they checked in, every lab test ordered, every medication administered, the doctor's notes, the diagnosis codes, and the time they were discharged. It's a mountain of information, and Sarah's job is to find the story hidden within it. But this data is rarely clean. It's a messy, chaotic reflection of a messy, chaotic environment. A doctor might type hypertension, while another types HTN. A nurse might accidentally enter a patient's weight in pounds in a field meant for kilograms. A crucial timestamp might be missing. So a huge part of Sarah's job, a part that often gets glossed over in flashy job descriptions, is data cleaning and preparation. She's like a master chef meticulously preparing her ingredients before she even thinks about cooking. She writes code, often using a language called SQL, which stands for Structured Query Language, to pull this data from the databases. SQL is essentially a specialized language for asking very specific questions to a database. She might ask, "Show me every patient who came to the ER in the last 90 days with chest pain, and give me the timestamps for their arrival, when they first saw a doctor, and when they were discharged." Once she has her ingredients, her cleaned-up dataset, the real analysis begins. This is where she might use tools like Microsoft Excel for quick calculations and pivots, but more likely, she'll use a powerful data visualization tool like Tableau or Power BI. These tools are her canvas. They allow her to transform rows and columns of numbers into interactive charts, graphs, and maps that tell a compelling story. She's not just looking for numbers. She's looking for patterns, bottlenecks, and anomalies. In our ER example, Sarah might build a dashboard. On one chart, she plots patient arrival times throughout the day. She sees the expected spikes in the morning and evening. But then, she creates another chart that visualizes the door-to-doctor time. And she spots it. A massive spike in wait times between 7 p.m. and 10 p.m., far worse than any other time of day. Her first thought, like the CEO's, is that they're understaffed. But she digs deeper. She pulls in staffing data and sees that, surprisingly, there are plenty of doctors and nurses on shift during those hours. The problem isn't the people, it's the process. So she keeps digging. She pulls data from the hospital's lab information system and the radiology department. She cross-references everything. And then the aha moment. She discovers that the bottleneck isn't getting a doctor. It's getting the results for basic diagnostic tests. The lab is overwhelmed during that specific window, causing a critical delay. Doctors can't make decisions without the data from blood tests and CT scans, so patients are left waiting in limbo. Now comes the most critical part of her job: communication. Sarah can't just email a spreadsheet to the head of the ER and say, "Fix it." That spreadsheet is meaningless to a busy doctor. Instead, she presents her visual dashboard in a meeting with hospital leadership. She walks them through the story. She shows them the chart with the glaring red spike in wait times. She shows them the data proving they have enough staff. And then she shows them the chart correlating the wait times perfectly with the lab result turnaround times. She has transformed a vague feeling of things are slow into a precise, data-backed diagnosis of the problem. Because of Sarah's work, the hospital can implement a targeted solution. Maybe they reallocate a lab technician from a less busy department during that 7 p.m. to 10 p.m. window. Maybe they invest in a new piece of equipment for faster blood analysis. They make the change, and a month later, Sarah runs the numbers again. The wait time spike is gone. Patient satisfaction scores go up. The doctors feel less pressure. Sarah didn't treat a single patient, but she improved the care for thousands. That is the power of a provider-side health data analyst. They are the internal consultants, the process improvers, the quality control experts who use data to make the entire system of care run better, safer, and more efficiently. Now let's switch gears and look at the other side of the coin. Because for every hospital providing care, there's an organization paying for it. This is the world of the payer-side analyst. These are the people who work for health insurance companies like United Health Group, Anthem, or Blue Cross Blue Shield. They also work for government payers like Medicare and Medicaid. If the provider-side analyst is focused on the microcosm of a single hospital or clinic, the payer-side analyst is looking at the macrocosm of an entire population's health. Their perspective is completely different. Their primary data source isn't the detailed electronic health record, it's claims data. A claim is essentially the bill that the hospital or doctor's office sends to the insurance company after you've received care. It contains codes for your diagnosis, the procedures you underwent, and the costs associated with them. Let's imagine another analyst, we'll call him Mark. Mark works for a large insurance company. He's not trying to fix wait times. He's trying to answer much broader questions. Questions like, which group of our members is at the highest risk for developing type 2 diabetes in the next 5 years? Or, is this new expensive cancer drug actually leading to better long-term outcomes than the older, cheaper one? Or, are there any doctors in our network who are ordering an unusually high number of expensive MRI scans, which might indicate fraud or unnecessary care? Mark's toolkit is similar to Sarah's, but often includes more statistical and predictive modeling tools. While he definitely uses SQL to query massive databases of claims, he's also more likely to use programming languages like Python or R. These languages have powerful libraries for statistics and machine learning that allow him to build predictive models. For example, he can take data from millions of patient claims, looking at their age, diagnoses, prescription history, and past doctor visits, and build a model that assigns a risk score to each member for developing a chronic disease. The impact of Mark's work is enormous. Let's say his model identifies a group of 10,000 members who are pre-diabetic and have a high probability of becoming diabetic within a few years. Treating diabetes is incredibly expensive, both for the insurance company and for the patient. So Mark's analysis doesn't just sit in a report. It drives action. The insurance company might use his findings to launch a targeted wellness program. They could proactively reach out to these 10,000 members and offer them free access to a diabetes prevention program, a health coach, or a discount on healthy food delivery services. This is a win-win-win scenario. The patient gets the support they need to avoid a serious chronic illness and live a healthier life. The insurance company saves millions of dollars in future medical costs. And the healthcare system as a whole benefits from having a healthier population. Mark also acts as a financial watchdog. He analyzes billing patterns to detect fraud, waste, and abuse. He might build an algorithm that flags a clinic that is billing for services on days it was supposedly closed, or a doctor who is prescribing a suspicious amount of a certain high-cost drug. By identifying these outliers, he saves his company millions of dollars and helps protect the integrity of the entire healthcare system. So while Sarah, our hospital analyst, focuses on operational efficiency and clinical quality inside the hospital walls, Mark, our insurance analyst, focuses on population health, risk management, and cost-effectiveness across an entire network of patients and providers. Both are health data analysts, but their day-to-day work, the questions they ask, and the impact they have are distinctly different. One is improving the process of care delivery, while the other is improving the health strategy for an entire population. And these are just two of the major lanes. Let's zoom out even further. Beyond the hospital walls and the insurance company headquarters lies a sprawling ecosystem of innovation and regulation. This brings us to a third, high-stakes arena, the pharmaceutical and life sciences industry. Think Pfizer, Johnson & Johnson, or a nimble biotech startup trying to cure a rare genetic disease. The health data analyst here isn't focused on a single patient's bill or a hospital's efficiency. They are playing a completely different game, with stakes that can be measured in billions of dollars and millions of lives. Their world revolves around one central monumental task: proving that a new drug or medical device is both safe and effective. This is the world of the clinical trial. Imagine you have a new promising cancer drug. Before it can ever reach a patient, you have to shepherd it through years of rigorous testing. A health data analyst in this space lives inside that data. They aren't just looking at spreadsheets, they're looking at the digital echoes of hope in biology. They are the first to know if the miracle drug is actually working. Their primary question is one of cause and effect. They'll take the meticulously collected data from a randomized controlled trial, where some patients get the new drug and others get a placebo, and they will torture that data until it confesses the truth. They'll use sophisticated statistical models to ask, did the group who took our drug have a statistically significant improvement compared to the group who didn't? That phrase, statistically significant, is everything. It's the gatekeeper. It's the difference between a multi-billion-dollar blockbuster drug and a failed experiment that gets shelved forever. But it's not just about efficacy, it's about safety. They are also digital detectives, hunting for adverse events. They'll sift through thousands of patient records looking for patterns. Is there a faint signal that this drug causes a rare side effect in a specific subpopulation? Are patients over 65 with a history of heart disease experiencing a particular problem? Finding that signal early can prevent a public health disaster. Missing it can lead to catastrophe. The pressure is immense. And once a drug is approved, the analyst's job transforms again. Now they're a commercial analyst, a market strategist. They're analyzing prescribing patterns across the United States. Which doctors are using the new drug? Which are sticking with the older competitor? They'll merge their company's sales data with publicly available physician data and demographic data to build a map of the market. They'll ask, are doctors in the Midwest adopting our drugs slower than doctors on the East Coast? If so, why? Is it a pricing issue? Is our marketing message not landing? They are guiding the entire commercial strategy of a massive corporation, all by telling stories with data. So the pharma analyst is part scientist, part detective, and part business strategist. They operate at the cutting edge of medicine, where data directly translates into the treatments that will be in your doctor's office 5 years from now. But what if you don't want the structure and decades-long timelines of big pharma? What if you want to move faster, to break things, to build something from the ground up? That brings us to our fourth lane, the hyper-caffeinated world of the health tech startup. This is where data analysis meets Silicon Valley. Think of companies building an app to help diabetics manage their blood sugar, a wearable that detects early signs of a stroke, or an AI that helps radiologists spot tumors more accurately. These companies are all about disruption. Their goal is to find one piece of the broken American healthcare system and fix it with technology. And the Health Data Analyst is the engine of that disruption. Here, the data isn't coming from a formal clinical trial. It's coming directly from the product. Every click, every swipe, every data point a user enters into the app is a breadcrumb. The analyst's job is to follow that trail. Their work is a relentless cycle of measuring, testing, and iterating. They live and breathe A/B testing. If we change the color of this button from blue to green, will more users sign up for our premium service? They'll run the experiment, analyze the results, and provide a definitive answer. They are obsessed with the user funnel. We have 10,000 people download our app every week, but only 1,000 complete the sign-up process. Where are those 9,000 people dropping off? Is step 3 too confusing? Is our form too long? They will pinpoint the exact source of friction and tell the product team what to fix. The health tech analyst is also proving the core value of the product itself. If you have a mental health app, you need to prove it actually makes people feel better. So the analyst will design studies and analyze user survey data to answer, do users who complete our 10-day mindfulness program report a measurable decrease in their anxiety scores? This data isn't just for internal improvement, it's what they show to investors to get more funding, and it's what they show to big hospital systems to convince them to buy the product. In this world, speed is everything. You aren't waiting years for a clinical trial to finish. You might be running a dozen experiments in a single week. The analyst here is often a generalist, part data analyst, part product manager, part growth hacker. They are deeply embedded in the product team, and their insights directly shape the evolution of the technology. They are building the future of how we interact with our own health. Finally, there's a fifth lane, one that operates on a totally different mission. This is the world of the public health analyst. These are the people working at the CDC, at state and local health departments, or for large nonprofits. Their customer isn't a patient or a user. It's an entire community, a city, a nation. Their goal isn't profit or user engagement. It's preventing disease, promoting wellness, and ensuring health equity. Think back to the early days of the pandemic. The maps you saw on the news showing hotspots and case counts? That was the work of public health data analysts. They were the digital first responders. They were taking in chaotic data from labs, hospitals, and testing centers across the country and trying to make sense of it in real time. They were building the models that predicted ventilator shortages and guided lockdown policies. Their work was, without exaggeration, a matter of life and death on a massive scale. But it's not always about pandemics. On a typical day, a public health analyst might be tracking a foodborne illness outbreak. They'll get reports of salmonella cases and start looking for a common thread. Are all these people who got sick shopping at the same grocery store chain? Did they all eat the same brand of lettuce? They are the modern-day Jon Snow, using data maps to find the contaminated pump and stop the outbreak. Or they might be tackling chronic issues of health inequity. They'll overlay maps of childhood asthma rates with maps of industrial air pollution and maps of household income. They'll ask the hard questions. Are children in low-income neighborhoods disproportionately exposed to air pollutants that trigger their asthma? Their analysis becomes the evidence that community advocates and policymakers use to fight for environmental justice and demand change. They evaluate the effectiveness of public health campaigns. After we ran our anti-smoking ads on social media for 6 months, did we see a measurable decline in vaping among teenagers in our state? They use data to hold public programs accountable and ensure that taxpayer money is being spent effectively to improve health outcomes. The public health analyst is a civic-minded data detective. The datasets are often massive, messy, and population-wide. The work is less about individual behavior and more about the systemic forces that shape the health of a society: poverty, environment, access to care, and public policy. It's a role driven by a mission of service, using data not for profit, but for the public good. So, we have 5 distinct worlds: the provider, the payer, the pharma company, the tech startup, and the public health agency. Each one needs sharp, curious data analysts. But the mindset you need to succeed in each is profoundly different. The definition of a win in one world might be irrelevant in another. It's not just about knowing how to code. It's about knowing what questions to ask. It's about understanding the fundamental mission of the organization you work for. We've seen the who and the where. But what about the how? What tools are these analysts actually using to wrangle this messy, complicated, and life-saving data? In the next part, we're opening up the toolbox. We're talking about the unsexy but essential world of SQL, the power of Python and R, and the visualization tools that turn boring spreadsheets into life-changing insights. This is where the rubber meets the road. So let's start with the absolute, undisputed, non-negotiable king of the toolbox: SQL. That's SQL, which stands for Structured Query Language. And if that name sounds boring and technical, ignore it. Think of SQL as the skeleton key to every data locked door in the entire healthcare industry. It's not really a programming language in the way you might think. It's a questioning language. It is the language you use to have a conversation with a database. And in healthcare, these databases are gargantuan fortresses of information, holding millions, sometimes billions, of records on patients, treatments, claims, and outcomes. You cannot walk up to that fortress and politely knock. You need the key. SQL is that key. Imagine you're an analyst at a major hospital system. A chief medical officer walks up to your desk and says, "We think there's been a spike in post-surgical infections on the 3rd floor, but we're not sure. We need to know how many patients who had knee replacement surgery in the last 6 months, who were treated by Dr. Evans or Dr. Smith, and were discharged with the antibiotic ciprofloxacin, ended up being readmitted with a sepsis diagnosis within 30 days. Now, without SQL, this question is an absolute nightmare. It's weeks of work, digging through paper files or clumsy software interfaces, cross-referencing spreadsheets, and probably making a dozen errors along the way. Your answer would be slow, and it would probably be wrong. With SQL, it's a conversation. You sit down, you open up your query tool, and you write something that looks a little like this. Select patient understudy from readmissions where surgery understudy equals knee replacement, and surgery understudy date is in the last 6 months, and surgeon understudy is Evans or Smith, and discharge for medication equals ciprofloxacin, and readmission diagnosis equals sepsis. You hit enter. And in less than 10 seconds, the database, this giant fortress of information, just hands you the list. It's not magic, it's language. You asked a clear, specific question, and it gave you a clear, specific answer. That is the foundational power of a health data analyst. Every other tool we're about to discuss is built on top of this foundation. If you take nothing else away from this section, hear this. You cannot get a job as a health data analyst in the United States without being proficient in SQL. It is the price of admission. Okay, so you've used your key, you've opened the door, and you've pulled out the data you need. But often that data is, well, it's a mess. It's like pulling 1,000 dusty boxes out of an attic. The information is there, but it's disorganized, it's dirty, and it's not ready to be shown to anyone. This is where the heavy machinery comes in. This is the world of Python and R. Now I know what some of you are thinking. Coding? Ugh. You're picturing someone in a dark room, hoodie up, staring at a screen of green text. Let's just demolish that stereotype right now. For a data analyst, learning Python or R is like a chef learning how to properly use a knife. It's not about becoming a software engineer. It's about having a power tool that lets you clean, slice, dice, and prep your ingredients, your data, with incredible speed and precision. So Python or R? It's the Coke versus Pepsi debate of the data world. Python, with its library called Pandas, is like a Swiss Army knife. It's incredibly versatile. It's fantastic at taking those messy, raw data files and cleaning them up. A process called data wrangling or munging. You can write a simple script to automatically fix inconsistent date formats, fill in missing values, merge multiple datasets together, and perform complex transformations on millions of rows of data in the time it takes to brew a cup of coffee. R, on the other hand, is more like a surgeon's scalpel. It was built by statisticians for statisticians. When you need to perform deep, rigorous statistical analysis like building predictive models to identify patients at high risk of developing diabetes, or conducting the kind of complex analysis needed for a clinical trial, R is an absolute powerhouse. So which one should you learn? The honest answer is that being proficient in one is essential, and knowing both is a massive advantage. But if you're starting from zero, the general advice is to start with Python. Its syntax is a bit more intuitive, its applications are broader, and it's an easier gateway into the world of data manipulation. You can always pick up R later. The key takeaway is this: SQL gets the data out of the database. Python R gets the data clean and ready for analysis. Now you have clean, organized data. You've even run some analysis and found something interesting. But right now, your finding is just a table of numbers on a spreadsheet. If you show that to a doctor, a nurse, or a hospital executive, their eyes will glaze over in 5 seconds flat. Data doesn't speak for itself. You have to give it a voice. You have to tell its story. This is where the artists of the data world come in. This is the job of data visualization tools, and the two biggest names in the game are Tableau and Power BI. These tools are your paintbrush and your canvas. They allow you to transform that lifeless grid of numbers into a vibrant, interactive story that a human brain can actually understand. Let's go back to that hospital readmission problem. You've done your analysis in Python and found that patients from 2 specific zip codes who are discharged on a Friday have a 40% higher chance of being readmitted. That's a huge discovery. But a p-value of less than 0.05 isn't going to convince a hospital board to change their entire discharge process. So you plug your data into Tableau. You build a dashboard. On the left, you have a map of the city with those 2 zip codes glowing red. On the right, you have a bar chart that clearly shows the spike in readmissions for Friday discharges compared to every other day of the week. You add a filter, so the hospital director can click on a specific surgeon and see their individual patient outcomes. You've just changed the entire conversation. You went from presenting numbers to presenting an insight. You're not just an analyst anymore. You're a storyteller. You're showing them where the problem is when the problem is, and you're giving them the tools to explore the why. That is the difference between a report that gets filed away and a dashboard that inspires a multi-million-dollar change in hospital policy that saves lives. Tableau and Power BI are similar in many ways. Tableau is often considered the gold standard for pure, beautiful visualization, while Power BI, a Microsoft product, integrates incredibly well with Excel and is often the more cost-effective choice for many organizations. Just like with Python and R, you don't need to be a god-tier master of both. But you absolutely need to be very, very good with at least one of them. Finally, let's talk about the unsung hero, the tool that's often overlooked, but is used every single day: Microsoft Excel. Yes, good old Excel. Before you scoff, understand this. Advanced Excel is a data analyst's secret weapon. We're not talking about making a simple budget. We're talking about mastering pivot tables to slice and dice data in seconds. We're talking about using functions like VLOOKUP and XLOOKUP to merge datasets on the fly. We're talking about Power Query to automate cleaning tasks. For smaller datasets and quick, ad hoc analysis, Excel is often the fastest tool for the job. It is the universal language of business, and you will be expected to be an expert in it. So look at how it all fits together. You get a request. You use SQL to pull the raw data from the fortress. You use Python to clean it, shape it, and get it ready. You use R to run a deep statistical model. You use Tableau to tell the compelling story in your data. And you use Excel to quickly share a summary table with your manager. It's not about one tool. It's an entire workflow. It's a symphony, and you are the conductor. Each tool has its part to play, and a great health data analyst knows exactly when to call on each instrument to create something meaningful. So now you know the tools. You've got the hammer, the saw, and the blueprint. But what does it actually feel like to build the house? What does a real day, a real week look like for a health data analyst? In the next part, we're pulling back the curtain. We're going beyond the job description and walking you through a day in the life. From the morning coffee and the first SQL query to the late afternoon aha moment that changes everything. You don't want to miss this. The alarm buzzes at 6:45 a.m. For a health data analyst, the first data point of the day is often your own sleep score from a smartwatch. A solid 82. Not bad. It's a quiet start, coffee in hand, scrolling not through social media, but through a curated feed of healthcare news, tech updates, and a few key industry journals. You're not just looking for headlines, you're looking for context. a new FDA-approved drug, a change in Medicare reimbursement policy, a published study on population health trends in your state. These aren't just news items. They are future variables. They are the seeds of tomorrow's questions. By 8:30, you're logged in. The inbox is already active. There's an automated email. The daily dashboard on emergency department wait times has refreshed successfully. Good. There's a chat message from a colleague in finance asking for the data dictionary for a claims table you built last month. You send the link, and then you see it. An email from the Chief Medical Officer's executive assistant. The subject line is simple, but it makes your focus sharpen. Question CHF readmission rates. Congestive heart failure. It's one of the most common and costly conditions for hospitals to manage. When patients are readmitted to the hospital shortly after being discharged, it's a red flag. It suggests a potential failure in their care plan, their discharge instructions, or their follow-up support. It's bad for the patient's health, and it's bad for the hospital's bottom line, as government payers can penalize hospitals for high readmission rates. The CMO's email is brief. Seeing a concerning uptick in our 30-day CHF readmissions last quarter. Can you dig into this? Need to understand what's driving it. Urgently. This is it. This is the starting pistol for the race. This isn't a routine report. This is a treasure hunt where the treasure is an answer that could change clinical practice and improve patient outcomes. First things first, you don't just dive into the data ocean without a map. That's how you drown. The first step is to clarify the question. You reply to the email, CCing the head of the cardiology department. Thank you for flagging this. To ensure I'm pulling the correct data, can you confirm the exact parameters? Are we defining readmission as any hospital visit within 30 days, or only those with a primary diagnosis of CHF? Are we including observation stays or only inpatient admissions? While you wait for a reply, you start prepping your workspace. You open your SQL editor, think of it as a specialized, high-powered command prompt for talking to massive databases. You connect to the hospital's clinical data warehouse. This is the holy grail. It's a colossal organized library containing anonymized data from millions of patient encounters, captured from the electronic health record system. The reply comes back quickly. Good questions. Let's define it as an inpatient admission for any cause within 30 days of discharge from an initial CHF admission. Focus on the last 2 quarters. Perfect. Now you can build. The real work begins. You start writing a query. Feels like a mix of being a detective and a linguist. You're crafting a precise question in the language of the database. You start with the first piece of the puzzle. Select patient_ID, admission rate from admissions in a table where primary diagnosis equals congestive heart failure, and admission between start of QE and end of Q4. This gives you your core group of patients, but that's just the first clause in a much longer sentence. Now, you need to find out which of these specific patients came back. This requires a more complex maneuver. You need to join this table of patients to the admissions table again, but this time looking for a later admission date for the same patient ID. You write a self-join, a clever piece of SQL logic, to find any subsequent admissions within that critical 30-day window. You hit execute. A loading icon spins for about 45 seconds, feels longer, and then a table of raw data appears. Thousands of rows. Each row represents a CHF patient from the last 6 months. A column at the end has a simple 1 if they were readmitted within 30 days and a 0 if they weren't. You export this raw data into a statistical software program or a Python script using the Pandas library. The first thing you do is confirm the CMO's suspicion. You group the data by month, and there it is, clear as day in a simple line chart. A steady rate for months, and then a distinct, undeniable climb over the last 3. The CMO was right. The what is confirmed. Now for the why. This is where the art meets the science. You have to become a skeptic, a theorist, a relentless investigator. You start forming hypotheses. Hypothesis 1. Is it a specific physician? Maybe one doctor's patients are having worse outcomes. You group the data by the attending physician for the initial admission. You run the numbers. Nope. The readmission rates are fairly consistent across all the top cardiologists. It's not one person. It's a systemic issue. Strike 1. Hypothesis 2. Is it a demographic factor? Maybe a specific group of patients is more vulnerable. You start slicing the data. By age group. By gender. by zip code, which can be a proxy for socioeconomic status. You run the analysis again. You find a small correlation. Patients from 2 specific low-income zip codes have a slightly higher readmission rate. This is an important finding and you make a note of it. It's a piece of the puzzle for sure, but it doesn't explain the recent increase. The demographics of the patient population haven't suddenly changed in the last 3 months. This clue is part of the background noise, not the main signal. Strike 2. You lean back from your desk. You've hit a wall. The obvious culprits aren't guilty. What changed 3 months ago? You start thinking outside the database. What operational changes happened at the hospital? You browse the internal company newsletter archives. New wing opened? No. New chief of cardiology? No. Wait a minute. There's an article from 4 months ago. Nursing education rolls out new CHF pathway discharge protocol. Your heart beats a little faster. This could be it. A new protocol. A new standardized set of instructions and educational materials given to CHF patients before they go home. It was designed to reduce readmissions, but what if it had the opposite effect? The problem is, the data on which patient received which protocol isn't in the main clinical data warehouse. It's not a billable event, so it's not in the financial data. After a few calls, you track it down. The nursing education department has been keeping a simple spreadsheet on a shared drive to track the rollout. This is the messy, unglamorous reality of data analysis. It's not always pristine databases. Sometimes it's hunting down a spreadsheet named CHF_pathway_tracker, _final_updated, XLSX. You find it. It's a simple list, patient ID and the date they received the new educational packet. Now you have to merge this completely separate, manually entered data source with your massive clean dataset from the warehouse. This is where the meticulous, detail-oriented part of the job kicks in. You import the spreadsheet. You write a script to clean up the formatting, check for errors, and standardize the patient IDs. Then, you perform the merge, creating a new column in your main dataset, received_protocol. It will have a 1 if they got the new education and a 0 if they got the old one. Your hands are literally hovering over the keyboard. This is the moment of truth. You adjust your code one last time. You're now grouping the patients not by doctor or by zip code, but by which discharge protocol they received. You are comparing the 30-day readmission rate for the old protocol group versus the new protocol group. You take a breath, and you hit execute. The result appears almost instantly, and it hits you like a ton of bricks. The readmission rate for patients who received the old protocol, 15%. The rate for patients who received the new, supposedly improved protocol, 24%. There it is. The aha moment. It's counterintuitive, shocking, and it's the most valuable discovery you'll make all month. The program designed to help was actually somehow making things worse. The data doesn't tell you exactly why. Is the new material too complex? Is it poorly translated? Is the training for the nurses who deliver it insufficient? But it points a giant, unmissable arrow directly at the source of the problem. The job isn't done. An insight sitting in your computer is worthless. You have to communicate it. You fire up a data visualization tool like Tableau or Power BI. You create a single, devastatingly simple bar chart. 2 bars. Old protocol versus new protocol. The difference is stark and undeniable. You draft an email to the CMO and the head of cardiology. You don't just attach the chart. You tell the story. Preliminary findings suggest a strong correlation between the implementation of the new CHF discharge protocol and the recent increase in 30-day readmission rates. You attach the chart. You clearly state your methodology, and you recommend the immediate next step. I advise a qualitative review of the new protocol and its delivery, in partnership with the nursing education and cardiology teams, to identify potential causes for this unintended outcome. You hit send. It's 4:30 p.m. In the span of a single day, you've gone from a vague, high-level concern to a specific, data-backed, actionable insight that could prevent dozens of patients from ending up back in the hospital. You didn't just crunch numbers. You followed a thread of curiosity, navigated messy data, and uncovered a truth that was hidden in plain sight. This is what a health data analyst actually does. And this is just one kind of day. But what about the other days? What happens when you don't work for a hospital, but for the insurance company that pays its bills? Or for the government agency that sets its policies? Or the tech startup trying to reinvent it all? The title is the same, Health Data Analyst. But the mission? the mission is completely different. The fundamental challenge shifts from helping one patient at a time to shaping the health of millions. So let's step out of the hospital's automatic doors, leave the clinical setting behind, and walk across the street into the gleaming glass tower of a major health insurance company. Here, you're not a clinical investigator. You're more of a financial detective, a guardian of the system's resources. Your patients are not people in beds, but rows in a database representing millions of members. The disease you're fighting isn't heart failure. It's fraud, waste, and abuse, a silent cancer that costs the U.S. healthcare system over $100 billion a year. Your day doesn't start with a question from a doctor. It starts with an alert from an algorithm. A small, unassuming dental clinic in a Florida strip mall has been flagged. The reason? They're billing for an unusually high number of a complex surgical procedure, one that's typically reserved for severe, rare cases. For a clinic of this size, the numbers just don't add up. It's a whisper in the data, a tiny signal in a sea of noise, and it's your job to find out if it's a fire. You don't pull a patient chart. You write in SQL query. You pull every claim submitted by that clinic for the last 3 years. Select asterisk from claims where provider underscore equals 1, 2, 3, 4, 5. But that's just the start. You join this data with the provider database to see who the dentists are. You join it with the member database to see the patient demographics. Are they all elderly? Are they all from the same geographic area? You start visualizing the data in Tableau. You see the billing for this one procedure wasn't just high, it was 0 for 2 years, and then it skyrocketed over the last 6 months. That's not a trend, it's a cliff. Your curiosity takes over. You start looking for connections. You run a network analysis in Python. Are any of the patients related? Do the dentists at this clinic also work at other clinics? And then you find it. A link. One of the dentists at the Florida clinic also has a provider number associated with a clinic in Texas and another in Arizona. You pull their data. It's the same pattern. A sudden vertical spike in the same high-cost procedure. You've stumbled upon a ghost network, a coordinated fraud ring operating across state lines, billing for phantom surgeries on real patients who have no idea their identities are being used. Your final output isn't a recommendation for a doctor. It's a detailed report, complete with visualizations, statistical evidence, and a clear narrative that you hand over to the company's Special Investigations Unit. They take it from there, working with law enforcement. You just saved the company millions of dollars. But more than that, you protected the integrity of the system. That money doesn't just vanish into a CEO's bonus. It's what helps keep insurance premiums from spiraling even further out of control for everyday people. You didn't use a stethoscope, but you helped heal a sickness in the financial heart of healthcare. Now let's zoom out even further. Forget one hospital. Forget one insurance plan. Let's look at an entire state, an entire country. Let's trade our corporate ID for a government one and step into the world of public health. Here, you're not a financial detective. You are a digital epidemiologist. Your job is to protect the population from threats they can't see. The alert on your screen isn't about billing codes. It's a report from a syndromic surveillance system called Essence. Emergency rooms in one specific county in the industrial Midwest are reporting a statistically significant spike in visits for unspecified respiratory distress. It's not COVID. It's not the flu. It's a mystery. Your job is to give that mystery a name. You begin by pulling the raw ER data. You map the home addresses of the affected patients. A cluster immediately appears, centered on a low-income neighborhood downwind from a large industrial complex. Coincidence? Maybe. But in public health, you don't believe in coincidences. You interrogate them. You become a data integrator. You pull air quality data from the Environmental Protection Agency's public APIs. You overlay particulate matter readings, ozone levels, and sulfur dioxide concentrations onto your map. You find a slight uptick in pollution on certain days, but it doesn't perfectly correlate with the ER visits. It's a piece of the puzzle, but not the whole picture. So you dig deeper. You pull meteorological data, wind direction, humidity, temperature. You find that the spikes in our visits all happened on hot, humid days when the wind was blowing directly from the northeast, from the direction of that industrial complex. Now you're getting somewhere. You use a Geographic Information System, or GIS, to create a plume model, showing exactly which areas would have been most affected by any potential emissions from the complex. The model is a near-perfect match for your patient cluster map. The final piece of the puzzle comes from a different, unexpected source. Social media data. You run a geofence keyword search for terms like weird smell, can't breathe, chemical odor in that neighborhood. And there it is. A flurry of posts from residents complaining about a strange metallic smell on the exact nights before each spike in our visits. You synthesize everything into a single, powerful briefing for the state's Department of Health. Your maps, your charts, your timelines, they tell an undeniable story. The data strongly suggests unreported, nocturnal chemical releases from a specific factory are causing acute health problems in a vulnerable community. Your work triggers an immediate investigation by environmental health officers. It leads to new air monitoring stations being installed, hefty fines for the polluting company, and a new public health initiative to distribute free air purifiers to residents. You never spoke to a single patient, but you became the voice for an entire community, using data as a megaphone to demand action and protect the air they breathe. But what if you don't want to protect people from what's already out there? What if you want to help create the cures of tomorrow? For that, we leave the government and enter the world of pharmaceuticals and life sciences. Here, you're not an epidemiologist. You are a clinical trial analyst. You're on the front lines of medical innovation. A pharmaceutical giant is in the final stage, phase 3, of a clinical trial for a groundbreaking new drug to treat Alzheimer's disease. Billions of dollars and a decade of research are on the line. The hopes of millions of patients and their families hang in the balance. Your job is to be the objective, unflinching arbiter of truth. Does it work? Is it safe? The data you work with here is different. It's not messy, chaotic real-world data. It's pristine, meticulously collected, standardized, and controlled. Every data point is a gold nugget. Your tools are different too. You're not just using SQL and Tableau. You're living in R and SAS, using advanced statistical models like Kaplan-Meier curves for survival analysis and mixed effect models to analyze cognitive scores over time. You run the primary analysis. You compare the group of patients who got the drug to the group who got the placebo. The result is, okay, it's positive. The drug shows a statistically significant, but very modest slowing of cognitive decline. It's enough to get approved by the FDA probably. A win, but not the home run everyone was hoping for. But your job isn't to just run the main analysis. It's to explore, to ask deeper questions. The company wants to know, are there certain types of patients for whom the drug works better? You begin slicing the data, by age, by gender, by the initial severity of the disease. Nothing. The effect is consistent and consistently modest. Then you have an idea. In the trial, they also collected genetic data on every patient, specifically looking for the presence of the APOE4 gene, a known risk factor for Alzheimer's. On a hunch, you stratify the entire analysis by this genetic marker. You rerun the models, and what you see makes your heart stop. For the 85% of patients without the gene, the drug has almost no effect. It's basically a placebo. But for the 15% of patients with the APOE4 gene, the drug isn't just modestly effective. It's a miracle. It almost completely halts the progression of the disease. The two lines on your graph, placebo versus drug for this subgroup, diverge so dramatically it looks like a typo. You check your code. You rerun it. You check it again. It's real. You haven't just analyzed a trial. You've uncovered the key to personalized medicine. Your analysis completely changes the drug's future. It's no longer a mediocre drug for everyone. It's a revolutionary cure for a specific, identifiable group of patients. It gets fast-tracked for approval with a companion diagnostic test for the gene. You just use data to turn a scientific disappointment into one of the biggest medical breakthroughs of the decade. You gave hope where there was none. So, you can be a fraud detective, a digital epidemiologist, or a clinical trial scientist, all with the same job title. The common thread is the data, the language of numbers that tells these human stories. But the tools you use, the programming languages you master, and the statistical concepts you deploy to translate that data into insight. Well, that's where the path to becoming an analyst truly begins. Let's open up the toolbox. Because being a health data analyst isn't just about having a curious mind. It's about being a master craftsman with a specific set of powerful instruments. Think of it like this. A world-class surgeon doesn't just show up with a sharp thing. They have scalpels for precision, forceps for control, and high-tech scopes to see what the naked eye can't. Your toolkit is no different. It's what separates an amateur from a professional, who can confidently dissect a problem and effect real change. At the absolute non-negotiable foundation of this toolkit is SQL, spelled SQL, often pronounced sequel. If you take nothing else away about the technical skills, burn this one into your memory. SQL stands for Structured Query Language, but what it really is the universal language of data. It is the one dialect that nearly every database on the planet understands. Imagine being able to walk into any library in the world, from the Library of Congress to a small-town archive, and ask a complex question in one common tongue, and getting the exact books you need instantly. That's SQL. You see, healthcare data isn't sitting in a tidy Excel file on someone's desktop. It lives in colossal, complex, and highly secure databases. We're talking electronic health record systems, insurance claims databases, pharmaceutical trial repositories, warehouses of information containing petabytes of data. You don't get to just browse it. You have to ask for what you need with surgical precision, and SQL is your voice. With a few lines of code, you can ask a question like, show me all patients between the ages of 50 and 65 who were diagnosed with hypertension in the last 24 months, who are also taking medication X, but have not had a follow-up appointment in the last 6 months. Think about the power of that question. In seconds, a SQL query can generate a list that a team of people might take weeks to compile manually. That list isn't just data. It's a targeted intervention list for a care management team. It's a group of people at high risk who need a phone call today. SQL is the tool that turns a vast, overwhelming ocean of data into a manageable, actionable stream of insight. It's not optional. It's the key to the entire kingdom. Now, once you've used SQL to pull the data you need, you often need to do more than just look at it. You need to clean it, reshape it, run complex statistical tests on it, and build predictive models. This is where the heavy machinery comes in. And in the world of data analytics, the two dominant power tools are Python and R. Let's start with Python. If SQL is the universal language, Python is the ultimate Swiss Army knife. It's a general-purpose programming language that has exploded in popularity because of its readability and its incredible ecosystem of libraries, which are like pre-built toolkits for specific jobs. For a health data analyst, a few of these libraries are your best friends. There's Pandas, which allows you to take that raw data you pulled with SQL and manipulate it with breathtaking power and speed, like Excel on hyperdrive. You can clean millions of rows, merge different datasets, and calculate new variables in the blink of an eye. Then you have libraries like Matplotlib and Seaborn, which help you create powerful visualizations, turning your clean data into compelling charts and graphs that tell a story. And then there's the really exciting stuff like Scikit-learn, a library that lets you dive into machine learning. You could use it to build a model that predicts a patient's risk of developing sepsis based on their real-time vital signs, or forecast emergency room admissions for the next week based on historical trends and weather patterns. Python is versatile, powerful, and increasingly the language of choice in the corporate healthcare world. On the other side, you have R. If Python is the Swiss Army knife, R is the dedicated, high-precision statistical laboratory. R was built by statisticians for statisticians. It breathes and sleeps statistical analysis. While Python can do everything, R's strength lies in its profound depth for complex statistical modeling and academic-grade analysis. When a pharmaceutical company is running a clinical trial for a new cancer drug and needs to present its findings to the FDA, the level of statistical rigor required is immense. The analysis has to be bulletproof. That is the world where R has traditionally dominated. Its visualization library, ggplot2, is legendary for creating beautiful publication-quality graphics. So the debate of Python versus R isn't about which is better. It's about context. Python is the versatile generalist, a jack of all trades and master of many, perfect for a wide range of industry jobs. R is the deep specialist, the go-to for heavy-duty research and academia. The modern analyst is best served by learning one deeply, usually Python for its broader applicability in the US job market, while being aware of the other. But here's a critical truth. Your brilliant analysis, whether done in Python or R, is completely useless if you can't communicate it. Your hospital's chief medical officer doesn't want to see 300 lines of code. She wants to know in 10 seconds whether the new surgical protocol is reducing infection rates. This is where the third category of tools comes in, the storytellers. I'm talking about data visualization platforms like Tableau and Power BI. These tools are your stage. They are the press conference where you present your findings to the world. They connect directly to your data sources and allow you, often with a simple drag-and-drop interface, to create stunning interactive dashboards. Imagine, instead of emailing a static spreadsheet of readmission rates, you send a link to a Power BI dashboard. The hospital administrator can open it, see a map of the city, and click on a specific zip code to see the readmission rate for just that area. They can filter by diagnosis, by doctor, by time of year. They can explore the data themselves, ask their own questions, and see the answers in real time. You haven't just given them a report, you've given them a dynamic decision-making instrument. You've transformed a passive observation into an active exploration. This skill, the ability to translate complex analysis into a simple, intuitive, visual story, is what separates a good analyst from a great one. It's what gets you a seat at the table where real decisions are made. Underpinning all of this SQL, Python, or Tableau is the true engine, your knowledge of statistics. The tools are just vehicles. Statistics is the knowledge of how to drive, the understanding of the rules of the road. Without it, you're just a person with a fancy car and no license, dangerous and likely to go in the wrong direction. You have to understand the concepts. Descriptive statistics, the mean, median, standard deviation, to simply describe what the data says. What's the average wait time in RR? Inferential statistics, using a sample to make a judgment about a larger population. We surveyed 200 patients about their satisfaction. Can we confidently say this represents the experience of all 20,000 patients we saw this year? This involves things like t-tests and confidence intervals. You need to understand regression analysis to determine relationships. How much does a patient's age, weight, and blood pressure actually contribute to their risk of heart disease? And crucially, you need to understand hypothesis testing. This is the bedrock of scientific inquiry. We have a hypothesis. We believe a new digital check-in system will reduce patient no-shows. We run an A/B test, we collect the data, and we use statistics to determine if the result we saw was a real effect or just random chance. Being a health data analyst means you are, at your core, a practicing scientist. So it's not a list of software to memorize. So workflow, a process of inquiry. You use SQL to ask a question and retrieve the evidence. You use Python or R to conduct the main investigation, cleaning the evidence and running your analysis. You use your knowledge of statistics to interpret the results with integrity and accuracy. And you use tools like Tableau or Power BI to present your case to the jury, the doctors, executives, and policymakers who will act on your findings. Mastering this flow is how you go from being someone who just looks at numbers to someone who wields them to change how healthcare is delivered. So let's pull back the curtain and look at the actual missions you'd be assigned. The real-world problems that land on a health data analyst's desk. These aren't abstract textbook examples. This is the day-to-day reality of the job, where your analysis has a direct, measurable impact on people's lives and the very fabric of our healthcare system. Imagine this scenario. You're working for a large urban hospital system. An executive walks into a meeting with a stark problem. Our 30-day readmission rate for patients with congestive heart failure is 22%, she says. That's 5% higher than the national average. It's costing us millions in penalties from Medicare. And more importantly, it means our sickest patients aren't getting better. They're ending up right back here, sicker than before. Find out why. This is where you, the analyst, become a detective. Your first stop is the crime scene, the data. You dive into the electronic health record or EHR system. You're not just looking at one spreadsheet, you're pulling from a dozen different databases. You use SQL to join tables containing patient demographics, age, gender, zip code, with clinical data like their lab results, the specific medications they were prescribed at discharge, and their length of stay. You pull in scheduling data to see if they had a follow-up appointment with a cardiologist, and crucially, if they actually showed up for it. At first, the data is just a chaotic sea of rows and columns, millions of data points. But you start to clean it, to shape it. You build your cohort. Every patient discharged with a primary diagnosis of congestive heart failure over the last 2 years. Then you start asking questions. Is there a correlation with age? Not really. What about a specific medication? Nothing jumps out. The initial clues lead to dead ends. This is a normal part of the process. It's frustrating, but you persist. You decide to look at the socioeconomic data linked to patient zip codes. And that's when you see it. A pattern begins to emerge. Patients from 3 specific zip codes, all on the south side of the city, have a readmission rate of almost 40%. It's a massive spike. Now you have a lead. You're no longer looking at 5,000 patients. You're focused on a group of 450. You dig deeper into their data, and you find the smoking gun. Over 80% of these patients miss their crucial 7-day follow-up appointment. The data tells you what is happening, but it doesn't always tell you why. So you take your findings to the clinical team. You present a map, a heat map showing the readmission hotspots. You show them the chart correlating missed appointments with readmissions. A nurse manager in the meeting looks at the map and her eyes widen. "Those are our transportation deserts," she says. "There's only one bus line that runs through that area, and it doesn't go anywhere near our cardiology clinics." Suddenly everything clicks. It wasn't a clinical failure. It was a logistical one. Elderly, sick patients couldn't physically get to their follow-up appointments. Their prescriptions weren't being refilled, their symptoms weren't being managed, and they were ending up back in the emergency room. Your analysis didn't just identify a statistic. It uncovered a story of systemic failure. And because of your work, the hospital doesn't just shrug its shoulders. They act. They launch a pilot program, partnering with the ride-sharing service to provide free, round-trip transportation for these high-risk patients to their first 2 follow-up appointments. 6 months later, you run the numbers again. The readmission rate for patients in those 3 zip codes has plummeted from 40% to 15%. The hospital is saving money, but more than that, hundreds of people are healthier, safer, and recovering in their own homes instead of a hospital bed. That is the power you wield. But it's not all about direct clinical outcomes. Let's shift gears from the patient's bedside to the hospital's operational backbone. Healthcare is a business, and efficiency can mean the difference between a hospital staying open or closing its doors, especially in rural areas. Here's another mission. The Chief Operating Officer is concerned about patient flow in the emergency department. "Our door-to-doctor time is averaging 75 minutes during peak hours," he explains. "Patients are leaving without being seen, our satisfaction scores are in the toilet, and I'm worried we're creating safety risks. We think we need to hire more doctors, but that's a multi-million-dollar decision. I need data to prove it." Your task is to map the entire patient journey through the ED, second by second. You pull timestamp data for every step: patient arrival, triage, registration, being placed in a room, first contact with a nurse, first contact with a doctor, lab orders, imaging orders, results returning, and finally discharge or admission. You use tools like Python or R to perform a time series analysis. You visualize the flow, creating what's called a process map. You're looking for the bottleneck. Where is the dam that's holding everything up? The executive team thinks it's a shortage of doctors. But your analysis reveals something completely different. The time from a patient being put in a room to seeing a doctor is actually quite short. The real delay, the massive black hole where minutes turn into hours, is the time between a lab test being ordered and the result being entered into the system. You segment the data by time of day. And there it is, clear as day. Between 5 p.m. and 11 p.m., the lab turnaround time triples. You found the bottleneck. It's not a doctor problem. It's a lab staffing problem. During the day, there are 4 lab technicians processing ED samples. After 5 p.m., there's only 1. That single technician is swamped, creating a backlog that delays dozens of treatment decisions across the entire department. You build a simulation model. What happens if we add just 1 more lab tech during that evening shift? Your model predicts that this single change would reduce the average door-to-doctor time by 40 minutes and cost a fraction of hiring new physicians. You present this not as an opinion, but as a data-driven conclusion, complete with charts, process maps, and a clear financial breakdown. The hospital makes the change. Within a month, patient satisfaction scores rebound, the number of patients leaving without being seen drops to nearly 0, and the entire department feels less chaotic. You didn't just run a report. You redesigned a critical hospital process and saved the hospital from making a costly, incorrect decision. Let's zoom out even further. Beyond the walls of a single hospital. Think about the massive insurance companies or public health organizations that manage the health of millions of people. This is the world of population health. Your new project. An insurer wants to be more proactive in managing its members with type 2 diabetes. It's a compassionate goal, but also a financial one. A single diabetic patient who develops kidney failure and needs dialysis can cost the system hundreds of thousands of dollars per year. Preventing that is a win for everyone. Your job is to build a predictive model to identify which members are at the highest risk of a serious complication in the next year. You're now working with a different kind of data: insurance claims, pharmacy records showing prescription refills, and lab value data from national lab companies. You're swimming in an ocean of information governed by strict HIPAA privacy laws. You use machine learning techniques. You train a model on years of historical data, teaching it to recognize the subtle patterns that precede a health crisis. The model learns that the highest risk individuals aren't just those with high A1C levels. It's the combination of factors: A person whose A1C is creeping up, who is also inconsistent with refilling their blood pressure medication, and who hasn't seen a primary care physician in over a year. These are the digital breadcrumbs that signal impending trouble. You run your model on the entire population of 200,000 diabetic members. It generates a risk score for every single person. It's like a credit score but for health risk. This list of the top 5,000 highest risk members is pure gold. It's an actionable, prioritized list. The insurance company doesn't just send them a pamphlet. They use your list to deploy their most valuable resource, nurse care managers. These nurses personally call the highest risk members. They help them schedule appointments, understand their medications, and connect them with dietitians. It's targeted, high-touch, preventative care, made possible entirely by your analysis. A year later, the rate of new dialysis patients from their diabetic population is down 18%. You haven't just analyzed data. You've built a data-powered crystal ball that allows the healthcare system to intervene before the crisis, saving fortunes and, more importantly, saving lives and livelihoods. Mastering this flow from the chaos of raw data to these kinds of transformative outcomes is the very essence of the profession. But to master that flow, you need a very specific set of tools. It's not magic, it's technology. And it's not about knowing 100 different programs. It's about achieving deep fluency in a core set of technologies that act as the engine for everything you do. Think of it as a pyramid. At the base, the foundation upon which everything else is built, are the non-negotiables. These are the skills that, if you don't have them, your resume doesn't even get a second look in the US job market. The absolute, undisputed king at the base of this pyramid is SQL, structured query language. If you take only one thing away about the technical skills, let it be this: you must learn SQL. I cannot overstate this. It is the language of data. Every major hospital system, every insurance company, every biotech firm stores its mountains of precious data, patient records, claims, lab results, billing information, in massive, complex structures called relational databases. SQL is the key to that vault. It's the universal translator that lets you speak directly to the database and ask it questions. Without SQL, you are standing outside the library, unable to read any of the books. You can't get the data out. You can't filter it. You can't join different datasets together. You are completely dependent on someone else to pull the data for you, which makes you an assistant, not an analyst. Every single day, a health data analyst is writing SQL queries. A physician wants to know, how many of our diabetic patients over the age of 50 have an A1C level above 8% and haven't had a checkup in the last 6 months? That's a SQL query. An administrator asks, can you pull the total billing amounts for all cardiovascular procedures performed in Q3 and join that with the primary insurance provider for each patient? That is a SQL query. We need a list of all patients admitted through the emergency department with a primary diagnosis of pneumonia, who were then readmitted within 30 days of discharge. You guessed it, SQL. It's the fundamental skill of data extraction and manipulation. Scan any job posting for a health data analyst on LinkedIn, Indeed, or any other major US job board. I guarantee you SQL will be at or near the very top of the required skills. It's the price of admission to the game. Sitting right alongside SQL on that foundational level is, perhaps surprisingly, Microsoft Excel. Now, I know what some of you might be thinking. Excel? Isn't that what my parents used to make a budget? Yes, but in the world of corporate and clinical analytics, Excel is a powerful, nimble workhorse. It is the Swiss Army knife of the data analyst. While you would never use it to store or analyze millions of patient records, it would literally crash and burn. It is indispensable for a different set of tasks. Once you've used your SQL query to pull a manageable dataset, say a few thousand rows of patient satisfaction survey results, Excel is often the fastest way to explore it. This is where you do your quick and dirty analysis. You'll use pivot tables to rapidly slice and dice the data, summarizing patient complaints by clinic location or by doctor. You'll use functions like VLOOKUP, or the more modern lookup to merge that data with another small table. You'll create simple charts and graphs for a PowerPoint presentation that a manager needs in the next hour. Excel is for speed, for ad hoc requests, and for cleaning and formatting smaller datasets before they go into a more formal report. Mastering pivot tables, advanced formulas, and Power Query within Excel can make you incredibly efficient and valuable. Don't ever underestimate it. The third piece of our foundational pyramid is a dedicated data visualization tool. The two titans in this space in the US are Tableau and Power BI. This is where you transform your sterile tables of numbers into compelling interactive stories. Because let's be honest, a hospital CEO or a chief of surgery does not have time to decipher a 10,000-row spreadsheet, but they can instantly understand a dashboard. Imagine, instead of showing a table of infection rates, you create a dashboard in Tableau. On one side, you have a bar chart showing the infection rates for different surgical procedures. On another, a map of the hospital floors, color-coded to show which areas have the highest rates. And in the corner, a line graph showing the trend over the last 12 months. Now, the magic happens when it becomes interactive. The CEO can click on a specific procedure, say knee replacements, and the entire dashboard, the map, the trend line, instantly filters to show data for only that procedure. They can see that the highest rates are on the 3rd floor and that they peaked in July. That is not just data, that is an insight. It's an answer. It's the starting point for a meaningful conversation about quality improvement. Power BI, being a Microsoft product, integrates seamlessly with Excel and the rest of the Microsoft ecosystem, making it a popular choice in many large organizations. Tableau is often praised for its aesthetic and powerful visualization capabilities. Honestly, the specific tool is less important than the skill itself. The ability to translate complex data into clear, intuitive, and actionable visual stories is a core competency of a modern analyst. So that's the foundation. SQL to get the data, Excel for quick analysis, and Tableau or Power BI to tell the story. If you master these three, you can get a job as a health data analyst. But if you want to excel, if you want to command a higher salary and solve more complex problems, you need to climb to the next level of the pyramid. This is where programming languages like Python or R come in. These are your heavy-duty power tools. When a dataset is too big for Excel to handle, we're talking millions or even tens of millions of rows, Python or R can process it with ease. When the statistical analysis you need is more complex than a simple average or sum, these languages provide vast libraries of sophisticated statistical functions. Python, with its famous Pandas library, has become incredibly popular in the data analytics world for its versatility and relatively gentle learning curve. It's a jack of all trades. You can use it to clean massive, messy datasets in ways that would be impossible in any other tool. You can use it to perform advanced statistical modeling, like running a logistic regression to identify the key factors that predict patient readmission. And with libraries like Matplotlib and Seaborn, you can create highly customized, publication-quality visualizations. R, on the other hand, was built by statisticians for statisticians. It is a powerhouse for pure statistical computing and is deeply entrenched in academia and clinical research. If you're working on a clinical trial for a new drug or conducting deep epidemiological research, you're very likely to be using R. For most hospital and insurance analyst roles in the US, Python is arguably becoming the more sought after of the two due to its general-purpose nature. But learning either one will significantly elevate your capabilities and your marketability. It signals that you can move beyond basic reporting and into the realm of advanced analytics and even predictive modeling. But here's the crucial part, the very peak of the pyramid, the thing that separates a good technician from a truly great health data analyst. It's domain knowledge. You can be the world's best SQL coder and a Python wizard, but if you don't understand the context of the healthcare data you're analyzing, your work is, at best, meaningless and at worst, dangerously misleading. This means understanding the alphabet soup of healthcare. You need to know what an EHR is, an electronic health record, and be familiar with the big players like Epic and Cerner, because their data structures will become the blueprint of your world. You must learn the language of medical coding. What's an ICD-10 code? It's the international standard for diagnostic codes. A patient doesn't just have diabetes, they have E11.9, type 2 diabetes mellitus without complications. What's a CPT code? It's how you bill for procedures and services. A simple office visit is different from a complex surgical procedure, and the CPT code reflects that. Without understanding these coding systems, the data is just a meaningless collection of numbers and letters. And above all, you must have a deep, unwavering respect for patient privacy. This means understanding HIPAA, the Health Insurance Portability and Accountability Act. This isn't just a box to check in your annual training. It is the ethical and legal bedrock of your profession. You will be working with protected health information, PHI, some of the most sensitive data in a person's life. Understanding how to de-identify data, how to work within secure environments, and how to ensure that every analysis you perform upholds the strictest standards of privacy and security is a non-negotiable responsibility. It's this powerful fusion of the technical and the clinical, the code and the human condition, that defines the modern health data analyst and unlocks a career path with enormous potential. So what does this future, this enormous potential actually look like? Where is this path leading? Because the role we've just described is only the beginning. We are standing at the edge of a technological and medical revolution, and the health data analyst is positioned right at the epicenter of it all. The next decade in this field won't just be an evolution. It will be a complete transformation, primarily driven by two words: artificial intelligence. Right now you might hear AI and think it's coming to replace jobs. In healthcare analytics, that couldn't be further from the truth. AI and machine learning aren't replacing the analyst. They are giving the analyst superpowers. Imagine, instead of just analyzing what has happened, like tracking last winter's flu outbreak, you're building predictive models that can forecast the next outbreak with stunning accuracy. You're feeding real-time data from emergency rooms, pharmacy sales, and even public transit usage into a machine learning algorithm that flags a potential spike in a specific zip code 3 weeks before it becomes a crisis. This allows public health officials to deploy resources, launch awareness campaigns, and save lives, all because you, the analyst, taught a machine how to see the future. This isn't science fiction. This is happening right now. Analysts are developing algorithms that can detect early signs of sepsis in hospital patients hours before a human doctor could, triggering an alert that brings a critical care team to the bedside. They're creating models that predict which patients are at the highest risk of readmission, so hospitals can provide targeted follow-up care, preventing a costly and dangerous return visit. They are working on personalized medicine, analyzing a patient's genetic makeup, lifestyle, and environmental factors to predict their risk for diseases like Alzheimer's, or to determine the single most effective chemotherapy drug for their specific type of cancer, minimizing trial and error and maximizing the chances of survival. The analyst of the future isn't just a data wrangler. They are a model builder, an algorithm trainer, and a digital soothsayer. The demand for people who can not only understand the data but also build and interpret these complex AI systems is about to explode. This is where the career trajectory truly launches into the stratosphere. So let's talk about that ladder. Where do you go from here? You start as a health data analyst, honing your skills, learning the clinical and business landscape. You prove you can deliver accurate, insightful reports. Then you climb. The next step is often to senior health data analyst. Here, the complexity of your projects increases dramatically. You're not just pulling data. You're leading major analytical initiatives. You might be the go-to person for the entire cardiology department's data needs, or the lead analyst on a multi-million-dollar project to optimize surgical suite scheduling across an entire hospital network. You're mentoring junior analysts. Your voice carries more weight in meetings, and your salary reflects that, often pushing well into the six figures. From there, the path splits. You can become a technical guru, a principal analyst or data scientist, the person they call when nobody else can solve the problem. Or you can move into leadership. This is the analytics manager or director of analytics role. Now, your job is less about writing the code and more about leading the team that does. You're setting the strategy. You're meeting with hospital VPs and department heads to understand their biggest challenges, and then translating those challenges into analytical projects for your team. You're managing budgets, hiring talent, and championing a data-driven culture across the organization. You've moved from finding the answer to deciding which questions are worth asking in the first place. The compensation here is significant, often reaching the high 100s or low $200,000 range and beyond. And the ladder doesn't stop there. A sharp, business-savvy director of analytics is on a clear track to executive leadership. Roles like Vice President of Information or even Chief Information Officer, CIO, or Chief Data Officer, CDO, are within reach. At this level, you are shaping the technological and data strategy for an entire healthcare system, managing a budget of tens of millions of dollars, and influencing decisions that affect the health of hundreds of thousands, if not millions of people. But what does it take to make that climb? What's the secret sauce that separates a good analyst from a truly great one? Who becomes an indispensable leader? It's not just about being a master of SQL, Python, or Tableau. The technical skills are the price of admission. They get you in the door. The X factor, the thing that will define your career, lies in the skills that can't be automated. First is relentless curiosity. A great analyst doesn't just answer the question they were given. They ask why 5 more times. When a manager asks, "What was our patient readmission rate last quarter?" The good analyst provides the number. The great analyst provides the number, but also points out that the rate spiked in a specific patient demographic, cross-references it with discharge data to hypothesize that a new follow-up procedure isn't working, and comes prepared with a proposal to test their theory. They hunt for the story behind the numbers. Second is the art of data storytelling. You can have the most brilliant insight in the world, but if you can't communicate it in a way that a busy, non-technical surgeon or CEO can understand in 60 seconds, it's useless. It's about turning a spreadsheet into a narrative. It's about creating a visualization that doesn't just show a trend, but evokes an emotional response and a sense of urgency. The best analysts are translators, bridging the world of pure data with the world of human decision-making. They don't just present findings, they build a compelling case that persuades people to act. And third, and perhaps most importantly, is clinical empathy. It's the ability to remember that every single row of data in your database is a person. It's a patient scared about a diagnosis, a family waiting for news, a doctor making a life or death decision. When you're cleaning a dataset and you see an outlier, you don't just delete it. You pause and you wonder what that outlier represents. Was it a data entry error? Or was it a patient with a 1 in a million condition whose story holds the key to a new discovery? This empathy guides your analysis, it grounds your work in reality, and it ensures that you are always using data to serve the ultimate mission of healthcare: improving human lives. So, after all of this, the final question is the most important one. Is this career right for you? This isn't just a job for someone who likes numbers. It's a calling for a specific type of person. It's for the puzzle solver who wants their puzzles to matter. It's for the tech-savvy individual who doesn't want to just optimize ad clicks, but wants to optimize patient outcomes. It's for the quiet observer who can find the signal in the noise, the pattern in the chaos, and use it to make a tangible difference. Ask yourself, do you feel a pull towards work that has a clear, undeniable, positive impact on society? Does the idea of sitting at the intersection of technology, medicine, and human behavior excite you? Are you driven by a deep-seated need to understand how things work, to uncover hidden truths, and to use that knowledge to build a better, healthier world? If the answer is yes, then this might be more than just a career path. It might be your path. The U.S. healthcare system is one of the most complex, expensive, and data-rich industries on the planet. It is filled with inefficiencies and unanswered questions, but also with boundless opportunities for improvement. It is a system that is crying out for smart, passionate, and empathetic people to help guide it into the future. It's waiting for people who can speak the language of data and use it to write a better story for patients everywhere. The journey is challenging. You will be tasked with solving problems that have no easy answers. You will carry the weight of knowing your work has real-world consequences. But you will also have the rare opportunity to go home every single day knowing that the code you wrote, the model you built, or the insight you uncovered might have helped someone get better care, helped a doctor make a smarter decision, or even saved a life. And in the end, there are very few careers that can offer that. If this journey, this fusion of code and compassion, excites you, then your next step begins right now. I want you to leave a comment below telling me the one thing from this entire discussion that surprised you the most about being a health data analyst. I read every single one, and I want to know what clicked for you. And if you're serious about exploring this path, make sure you subscribe and turn on notifications, because we are just scratching the surface of how data is fundamentally reshaping our world. Thank you for watching.